perinatal suicide prevention. Oh, thanks, Sydney. Got it. And then we're going to hear about Zero Suicide and how one organization is using that campaign. And then finally, we're going to wrap up with some Q&A and to give you guys an update on the upcoming labor and delivery nurse stigma and bias training that we're hosting in October. All right, Sydney, if you want to go to our agenda slide. Yep, so that's everybody we're going to hear from. We'll introduce our speakers individually before they go so that you guys know who you're hearing from. But I always want to ground us in why we're here. And the Colorado Department of Public Health came out with their most recent legislative report that covers maternal mortality from 2016 to 2020. We've been eagerly awaiting this report. It's sobering details, right? This report is always a difficult one to process, with the reality of how birthing and postpartum people are dying in Colorado. We can't overstate what an impact mental and behavioral health care has for the people who are dying. And so their most recent report said that 1 in 2 patients had mental health or substance use as a contributing factor to their death. That's a huge percentage. And then I think what was even more surprising to me is that 1 in 5 pregnancy-related deaths that weren't even due to the leading causes of maternal mortality, which is suicide and unintentional drug overdose, still had mental health or substance use as contributing factors to their deaths. And so again, I think it's important for us to remember why we're here today, and this is it. If you're interested in CDPHE's report, it's there on that QR code. We will definitely share these slides out at the end as well. And so we'll go on to the next slide here. And those of you who have been with us all year, you know that we've dedicated a really small portion of every coaching call to talk about quality improvement. At its heart, this is a quality improvement program with the goal of improving care and outcomes for birthing people during the hospital birth admission. We've walked really stepwise through the model for improvement and given lots of suggestions. All of those are recorded. We'd be happy to talk about those during one-on-ones if you guys want to go back to the basics. But we're getting towards the end of our year now. I cannot believe it. This is like one of our last 3 coaching calls of this year. And so it's really important that we start to talk about, of the really excellent changes that you all are leading at your facilities, how can you sustain that work? Right? We don't want to just make short-term changes. We don't want this to be a 1-year project. We want this to be care outcomes that we're changing in the long term. And within our program, there's a few things that we measure to ensure that that's happening at your facilities. Your champions are probably familiar with these because we ask them to fill out questionnaires on how your progress is on these sustainability measures every quarter. But the things that are going to sustain the positive care improvements that you guys are making are the use of a validated screening tool. Almost every one of our hospitals is doing that. Establishing a multidisciplinary work group so that beyond the life of your participation with CPCQC, you have a community in your local hospital that can support this work. It looks like having a resource document for your staff so that they know how to consult and refer for patients experiencing substance use, revising your pain management guidelines, and then talking about how you can embed staff education, either onboarding education or yearly required education for your staff on perinatal substance use. And finally, we talk about hospital policy revision and review. And that's the one I just wanted to briefly talk about today. So Sydney, if you want to go to the next slide. CPCQC recently developed a model hospital policy for the management of perinatal substance use. And so this policy covers the very core of what SUD is about. And so all of the steps in this policy are familiar to you all who are participating in our program. But we had many hospitals requesting that we actually put it in writing in a way that they could influence the hospital policy at their facilities. We were finding that many hospital policies are really outdated, using very stigmatizing language, practices that are not evidence informed. And so we used the inpatient safety bundle to inform a hospital policy. We are not expecting hospitals to pick up this policy and adopt it as is, but it's a really excellent guide that you can take to the policymakers at your institution and the leadership at your institution and say, this is best practice. How can we move our policy to get one step closer to what is best practice? It's here on the QR code. We will be sure to share it out for you. If you guys want to schedule a session with us to talk about this policy and how you can introduce it to your leadership, we'd be happy to do that as well. And the last thing I'm going to share before we get into our main content is the toxicology guidance document. So Cindy, you can go to the next slide. And this document is from Support Colorado. It's been out for a while. We've introduced it to you many times, but it's an excellent companion piece to the hospital policy document that we just shared with you. The hospital policy that we've developed is the basic care practices. We don't go into the nitty-gritty of toxicology testing and guidance because Support Colorado already did that. They put all the best minds together in Colorado to come up with this guidance, and it's excellent evidence-informed guidance. And so we always want to make sure that you guys have that on hand. Again, if you're taking that next step to try to influence the policy documents at your hospital, our basic hospital guidance policy paired with this toxicology guidance is a perfect place to start. So happy to talk more about sustainability and how you guys can move there, but I think that this is a perfect foundation. All right, Sydney, we can go to the next slide, because let's get into the good stuff. Today we're talking about suicide prevention in the perinatal space. And so we have an expert speaker here with us, Dr. Lindsay Levin. She received her MD from the University of Colorado School of Medicine. She completed her psychiatry residency at the University of Washington. She completed additional fellowship training in consultation liaison psychiatry at UCSF. And she is now the assistant professor in the Department of Psychiatry at CU, where her clinical interests include psychiatry, integrated care, and psychosocial oncology. So we're fortunate to have her. Please welcome. Thanks, Lindsay.
Gotta unmute myself. Okay, give me 1 second. I'm just gonna be sharing my screen here. And, oops. Are you guys seeing presenter view or, sorry, I have 2 screens.
We can see presenter view, but it's up to you. It still looks fine to us.
Let me see if I can. I would like it just to be slideshow. Okay, swap. There we go. Okay, got it figured out.
You did it.
Hooray! All right. So thank you so much for having me, Amber. I appreciate it. This is such an important topic, so I'm thrilled to be able to speak with you all about perinatal suicide prevention and thinking about ways to promote awareness, improve screening, and our response when someone is struggling with this. So the objectives today would be to just understand the importance of screening for suicide during the perinatal period, to be able to identify dynamic and static risk factors, as well as warning signs for suicide risk in this population, to have some framework for suicide risk assessment during pregnancy and postpartum. I think it can be helpful in any care setting to guide conversations that you might be having with patients that you're interfacing with. And then lastly, to be able to describe strategies for suicide risk intervention and safety planning for those who are at risk. So, as Amber was mentioning during her talk, suicide and drug-related deaths are leading cause of maternal mortality. Suicide in particular accounts for on average 20% of maternal deaths. So this is obviously very high. And suicidal ideation, suicidal thoughts are particularly risky in perinatal individuals because they are more likely to use more lethal, more violent means when they attempt suicide. So studies looking at this have shown higher rates of, hanging or jumping as the means by which perinatal individuals have attempted, which tend to be more lethal overall, versus the non-perinatal population. The most common method is overdose. So this suggests that when someone is really struggling with suicidality in this time period, the intent behind these acts is often quite high, and they have a higher risk of completed suicide as a result. Concurrently, perinatal individuals are less likely to be receiving treatment at the time of their deaths versus individuals in the non-perinatal population. And based on the data from maternal mortality review committees, most of these deaths are preventable, which obviously I think is a sad thing to sit with. But on the other hand, it's also, I think it gives us opportunities for intervention to help prevent future deaths by suicide amongst birthing individuals in pregnancy or in the postpartum. So the prevalence rate of suicide is a little bit variable depending on which study you're looking at, but one of the more recent ones suggested that the completed suicide rate was around 3 per 100,000 live births here in the US. That said, despite completed suicide being relatively rare, suicidal thoughts are actually much more common in the perinatal period. Um, just some stats looking at different patient populations. So amongst patients in general obstetric care, uh, rate of suicidal thoughts is 2 to 5%. Amongst women veterans, 10%. For perinatal individuals with depression or who are receiving mental health treatment, it's even higher, up to 14%. And then, NICU patients, patients whose babies are in the NICU, the risk of suicidal thoughts is around 9%. So obviously, I'm not covering every single population, but hopefully this highlights that suicidal thoughts themselves are relatively common. Looks like I got muted quickly. Can you guys hear me? Okay, perfect. I would imagine, though, that those numbers might even be an underestimate of what the actual prevalence of suicidal ideation is in this population. There's a lot of stigma that's associated with reporting suicidal ideation. So I could imagine patients in these studies might not have felt totally comfortable to fully disclose, maybe worry about, oh, is CPS going to be called if I say that I'm suicidal? In terms of the prevalence rates for completed suicide itself, it's a relatively rare event. The rarer an event is, the harder it is to get really accurate prevalences. Additionally, the pregnancy checkbox on death certificates was only relatively recently added to kind of, mark that status. That was added in 2003. And then deaths associated with suicide or overdose in pregnancy and that first year postpartum weren't even included in the maternal mortality death counts. For a long time, it was only in 2012 that those were added. And obviously, they found that these are the leading causes of maternal mortality. So, in terms of screening for suicidality, I think most health organizations that are centered around the care of birthing individuals and their infants are doing depression screening. That's kind of a universal recommendation amongst multiple different organizations. Whenever you're screening for depression using validated tools, you are inherently screening for suicidal ideation. The suicidality piece is built into those things. But the American College of Obstetricians and Gynecologists recently updated their clinical practice guidelines this year. Prior to this, they recommended screening for perinatal depression just once during the perinatal period, but they updated this to include more specific time points, the initial prenatal visit, later in pregnancy, and at the postpartum visits. Additionally, they recommended kind of even going one step beyond further, that when someone answers yes, that they're having thoughts of self-harm or suicide, that the clinicians be able to assess for the likelihood, acuity, and severity of the risk of suicide and then arrange risk-tailored management. So in other words, they have to have some sense of how to do a suicide risk assessment and get these people connected with the mental health care or substance use treatment supports that they might need in the situation. The American Academy of Pediatrics recommends depression screening in postpartum individuals during well child visits at 1, 2, 4, and 6 months of age, and then referring those who screen positive for appropriate treatment. This is useful that the American Academy of Pediatrics advocates for screening at these timelines because a lot of times the postpartum visits end at 6 weeks. And we'll talk about the timing of perinatal suicide deaths. The different screening instruments that are used, and there's obviously a number that are out there, but the two most commonly used looking at depression are the Edinburgh Postnatal Depression Scale and the Patient Health Questionnaire 9, PHQ-9. Question 10 in the EPDS is specifically the one that looks at thoughts of suicide. And I think it's helpful to actually look at how the question is phrased in both of these questionnaires. So the EPDS asks it in terms of the thought of harming myself has occurred to me. Yes, quite often, etc. In the patient health questionnaire 9, it phrases it slightly differently. They ask, over the past 2 weeks, how often have you been bothered by the following thoughts that you would be better off dead or thoughts of hurting yourself? So I think it just highlights that actually the EPDS question only is asking about self-harm. So you might be missing out on questions that are having thoughts of not wanting to be alive anymore, but it hasn't yet, reached quite that point of having, suicidal plan or specific suicidal ideation. We'll talk. There's kind of suicidal ideation is not really a black and white thing. It's not a yes or no thing. There's really a range of suicidality, and so I think it's helpful to be aware of it. I do think that the PHQ-9 question asks it in a broader way that might capture more of these patients who screen positive than the EPDS. In terms of the timing of death, this is a graph that came from a study out of Canada in 2017. And as you can see, suicide deaths did occur throughout pregnancy and into the postpartum, with the highest rates of suicide actually happening during the third trimester in the study. And then notably, the vast majority of deaths happened after 6 months postpartum, between 6 and 12 months postpartum. I think this is just useful to be aware of because I think it really highlights a gap in our screening that we have in place right now. As I mentioned, the American Academy of Pediatrics can capture people up to 6 months, but they don't advocate for maybe continued screening at 9 months or a year, when this is really when we see most of our suicide deaths. The other point of vulnerability that I would add to this study is that the first 6 weeks postpartum, even though the rate in this particular study didn't show a huge spike, I do conceptualize as a period of risk. It's often a time period where we can see the onset of very severe mental illness in the postpartum. For example, postpartum psychosis is a very serious perinatal mental health condition that's associated with elevated rates of both suicide and infanticide that often shows up, within the first few weeks after delivery. So that is another, point of risk. And I think that, usually people are able to better capture that with the screening systems that we have in place. But yeah, the 6 to 12 month time is, we don't have great universal screening recommendations for that at this point. So one thing I want to note is that for most perinatal suicide deaths, when they've looked at the course of a person's care during this time period, they found that the vast majority, if not all, of these patients had very high rates of health system contact before their death. And it wasn't just mental health, it was in all of these different interdisciplinary settings. They had contacts in primary care, in OB-GYN, outpatient settings, in the emergency department. And the majority had at least one inpatient or emergency department visit between delivery and death in the postpartum. I think this is good because it really highlights that there's lots of opportunities for detection and intervention. And I think it also highlights that, identifying those who are at risk for suicide, shouldn't just be relegated to any one discipline. It's not just the job of the mental health providers or, OB-GYN on the outpatient setting when they're seeing them postpartum. It really needs to be an interdisciplinary effort. And I think especially there could probably be room for improvement in inpatient or emergency department settings. Because I know that substance use is something that you guys have been kind of really focusing on in terms of how to help support perinatal individuals around substance use. Just want to highlight that there is a very, very strong connection between substance use, mental health, and suicide. I think it makes intuitive sense that, this the perinatal period is a very risky time for birthing individuals. And people in the postpartum, there's heightened stressors, there's sleep deprivation, there's caring for a newborn, which can be very stressful for many. In the context of all of this stress, someone's mental health might become, worse. They might be struggling with more depression or anxiety. And when that happens, sometimes people will turn to substances in the postpartum. A lot of people can maintain sobriety during pregnancy, but then just with all of the added stressors, an exacerbation of mood and anxiety symptoms in the postpartum, that can lead to escalating use. That might lead to a lower threshold to act on suicidal thoughts. So all of these things are very closely connected. And that's really borne out in the literature that's looked at this relationship. Substance use is a risk factor for suicide. Pregnant individuals with substance use are, one study, 3.7 times more likely to feel suicidal versus those without. We know that unintentional drug overdoses are on the rise, accounting for even more maternal deaths in 2020 versus 2016. I thought this was interesting. The trend of when these deaths are occurring mirrors what we see for perinatal suicide deaths. Substance-related deaths also peak at more than 6 months postpartum, between 6 months and 1 year, which I just think again highlights we have this massive gap between the 6 months and 12-month postpartum time period where unfortunately I think patients are really falling through the cracks. I won't go over this, but just to reiterate the interconnection of all of these things that Amber was highlighting. So what can we do? And I know that many of you work in inpatient settings. So number one, I think looking at systems, what screening processes are in place at your institution. Ideally, there would be universal screening whenever someone is admitted for antepartum, for labor and delivery, for postpartum, and then having a system in place if there is a positive response. And obviously, just highlighted the importance of this happening not only in the outpatient settings, but also in inpatient and emergency settings. If your institution is not at a place yet where they are doing universal screening, I think it's important to just have this be a part of pregnancy and postpartum care whenever someone is admitted, whenever you're seeing someone in an emergency department. Have a conversation, provide education about perinatal mental health conditions and substance use. Normalize this. Like, these things are really, really common, and ask about suicidality. Like I said, having a framework for risk assessment and even more importantly, awareness of warning signs can be really helpful. And then just know your resources. What are the resources if someone endorses suicidal ideation at your institution? Is there psychiatry consult service there? What are your resources on the outpatient settings? Do you have partnerships with any local institutions where you could refer these patients? Just kind of having a sense of what is available to you. So this is a framework that I really like for suicide risk assessment because it's very simple. It's called the SAFE-T suicide risk assessment. It's a 5-step evaluation and triage. It was designed to be employed in very busy primary care settings. So it's simple. It's easy to remember. There's no forms necessarily that you have to fill out. It's a framework for understanding, what is this patient's risk of acting on suicidal thoughts. So the 5 steps are to identify the patient's risk factors, have a sense of what are their protective factors that might mitigate their risk or prevent them from acting. You'll conduct a suicide inquiry, which is really asking them about the nature of the suicidal thoughts that they're having. Then based on that, determine their risk level and interventions. And then the 5th step is documentation. So the risk factors can be broken down into static risk factors and then dynamic risk factors. Static risk factors are really more demographic risk factors. They're not modifiable. I think they're just important to be aware of so that you can understand, oh, this might be a person who needs more support or is just kind of chronically at higher risk versus, someone else. So some of these static risk factors include a prior history of suicide attempt or self-harm behavior, personal history of psychiatric illness or substance use disorder, even a family history of such. If a patient is younger, unmarried, history of childhood abuse, financial stress or unemployment, exposure to disaster, conflict, or war, history of social, racial, or gender discrimination, and then patients who live in rural settings or have housing instability are also at higher risk. Of these risk factors, the riskiest risk factor, the ones that really increase chronic risk the most, is having a prior history of suicide attempt or self-harm behavior. There are also static risk factors that are more specific to the experience of pregnancy and the postpartum itself. Some of those include having an unplanned or unwanted pregnancy, if someone experiences birth trauma in the course of their hospital admission for delivery, if their baby has any complications leading to NICU admission, um, if they have fetal loss or stillbirth, that is another risk factor. They have a partner who rejected paternity. Medical complications during pregnancy, such as hyperemesis, can contribute to level of distress, despair, and can increase risk. Other medical comorbidities or chronic pain, just having a history of that is a risk factor. Any abrupt onset of psychiatric symptoms at any point is a risk factor. And then a history of psychiatric admission, especially during the postpartum period, is of these really one of the riskiest risk factors. One study indicated that it increased risk of completed suicide by up to 70 times versus those who did not require psychiatric admission. So this is one to keep an eye on. Dynamic risk factors are really the ones that we pay even more attention to because they're modifiable. There's actually something we can do about it to change a person's risk level. So some of the things that we look at is what are the current mental health symptoms that they're dealing with? Is it what are the symptoms that are most bothering the patient? Insomnia, low mood, hopelessness, rage, anxiety, panic, psychosis. Suicidal ideation itself is, being a symptom. Psychosis in particular, like I mentioned, postpartum psychosis is something that is really strongly correlated with a heightened suicide risk. Current substance use, especially if there's new or escalating use, is a significant area that we'd like to intervene on. What is the patient's degree of social support? Are they in a situation where there's significant intimate partner violence or even family conflict that's highly distressing? What is the patient's relationship with the baby? Are they having difficulties bonding? There are interventions to help address that. Are they engaged in any mental health treatment? Oftentimes, patients are struggling with their substance use, with their mental health symptoms, and don't have any formal treatment support. Especially with pregnancy, a lot of times patients actually may have been engaged with mental health treatment, have been on a medication, but then abruptly stopped their medication in pregnancy related to concerns about its, medication safety, and that has been shown to correlate with higher risk of symptom relapse during pregnancy and especially in the postpartum. And then access to firearms or other lethal means is something that we can intervene on as well. So sometimes a patient might not explicitly say, hey, I'm having suicidal thoughts. It might be more things that you're noticing, especially for those who are caring for patients in the inpatient setting, that might trigger alarm bells for you. So these would be if the patient seems to have little interest in caring for their personal hygiene, if there's clearly a change in their appetite or sleep patterns, if there's a history leading up to admission of missing healthcare appointments, if someone mentions that they're withdrawing from social supports in their lives, that's a red flag. If they mention maybe they're no longer engaging in important hobbies or activities, if there's a history of or recent reckless behavior such as substance use, reckless driving, fighting with others, that can be a warning sign that maybe something is going on that we can intervene on. Then there's more obvious things like the person talking about harming themselves, planning for suicide, saying goodbye to loved ones, giving away treasured possessions. So obviously there's a wide range of warning signs that might be present before someone attempts suicide. Additionally, there might even be more subtle things that a person just says in the course of you taking care of them that might signal, oh, maybe I should ask more about this. A lot of times, these are statements that might suggest a significant degree of shame, guilt, distress, despair. So, just for example, I'll read some of these. I can't do this anymore. I want to escape. No one would notice if I was gone. Feel so lonely. No one understands or cares. I'm a terrible mom. My baby deserves better. I have no idea what I'm doing. I feel useless. What's the point? Things are never going to change. My baby would be better off without me. So obviously this isn't capture every single thing that a patient might say that might have you pause and kind of, maybe I should ask more. But it gives you kind of a sense of the flavor of statements that patients might say in passing that could suggest that actually they are struggling with suicidal thoughts, even if they're not explicitly saying that in the moment. Protective factors for suicide are also something that we want to be aware with, because these are the things that we really want to try to bolster, because they can prevent someone from acting on suicidal thoughts that they might be having. So, what is their degree of social support? The more social support, the better. Do they cohabitate with their partner? Do they have hope for the future? Do they think things will get better? What is their level of distress tolerance? Do they have coping skills? Are they engaged in mental health treatment or not? Do they have good rapport and alliance with their providers? Do they feel like, do they have other kids that they feel like they have a responsibility towards? Do they have pets that they, feel a sense of responsibility towards? I've had many patients where just the presence of their other kids or pets that they really care for are really the main things that have prevented them from acting on thoughts of suicide in the perinatal period. Do they have religious beliefs against suicide? That can sometimes be protective. Fear of acting on suicide. And then intact reality testing. This really gets to, is a patient psychotic or not? Psychotic patients do, typically are not totally, in line with reality in terms of the way that they're thinking about things. And for that reason, they are at higher risk of completed suicide. So the next step is the suicidal inquiry, and this is where we look at the hierarchy of suicide assessment. So this is really that spectrum. We can go from having thoughts of not wanting to be alive, having thoughts of death, all the way to having suicidal ideation with a plan, with means, and they want to act on it. They have intent. So there's different ways that you can ask through this spectrum. And I do like to start with thoughts of death. Are you feeling hopeless? Are you having thoughts that life is not worth living? Thoughts of not wanting to be alive anymore, as a place to start screening. If they say yes and tell you a little bit more, you might want to ask explicitly about thoughts of suicide. Are you having thoughts of killing yourself? And get a sense of what that's looking like for this person. How often? How intense? Has it been getting worse in the past day or two? Is this a change from their baseline? There are patients that struggle with chronic suicidal thoughts and they just kind of always have them. And maybe this isn't a change from their baseline. On the other hand, it very well might be an escalation from baseline, or they might be new suicidal thoughts, all of which would be more concerning. If they say yes to all of this, then you want to ask about plan. Have you thought about how you would hurt yourself? Do you have a specific plan that you keep coming back to? Just getting a sense of what that looks like, because it can help to inform safety planning and means restriction, which we'll talk about. You'll ask about, are there means available? Do you have access to the means for the plan you're thinking about? Lethal? Do you have access to guns at home? That's something we universally ask about in mental health, just because the lethality is so high when someone uses a gun. How easy would it be to act on your plan? And they don't really want to get it. Someone might have all of these things available, means a plan, suicidal thoughts, but they might not have intent. They might be really scared about acting on this, really not want to go there. So you'll want to get a sense of, like, do they want to act on it? So you can ask them that. When and where would you do it? Are they engaging in preparatory behaviors? How far have you gotten? And then I can think it can be helpful to really explore a patient's ambivalence about living or dying. If you were to end your life, what do you think that would accomplish? Is there anything preventing you from acting? That's a lot of times where you can pinpoint, what are those protective factors? It might be kids, it might be their job. It really depends on the person. What are your reasons for living? What's helping you to keep going on day by day? That can really help you to explore, where is this person's intent level? When you are asking these questions, how you approach it and the wording you use is important. And I think it's important just to get comfortable with asking these questions, because how you ask them really affects the likelihood of getting a truthful response. I think suicidal ideation is very stigmatized. It can be very hard for a patient to talk about. It can be overwhelming. And so, you just having a way to ask these questions in a non-judgmental, just very matter-of-fact, non-condescending way can be helpful. One strategy that I like to use is just to normalize it as you are asking about it. So, this is just one phrasing. When people are feeling overwhelmed, sometimes they may feel like life is not worth living. That's really common in the postpartum period when you're dealing with all these different stressors. Have you been feeling this way? Have you ever felt this way? It can also be useful to use the person's language. They might not say, again, I'm feeling suicidal. They might say, like, oh, I just feel like I can't live like this. And so you can just ask, oh, you said that. Can you tell me more? What does that mean to you? You want to try to use open-ended questions as much. So if you have someone with a positive screen on their EPDS with a positive question 10, you can bring it in and say, hey, I noticed on your depression screening that you said yes to this question about having thoughts of harming yourself. Tell me more about that. Can you tell me a little bit more about that? I work with medical students a lot in at the University of Colorado, and sometimes they will ask questions in a very yes no way, or it's very clear that they're uncomfortable about asking the question. They'll be like, oh, you're not having suicidal thoughts, right? And it's very clear that they're kind of making like a positive response, like, no, you can't have suicidal thoughts because I don't want to deal with it. So I think the more you can avoid that closed-ended questioning, really the better. If there is any hesitation or resistance, I think it's important to validate the patient about their fears, but you can also provide some reassurance and express hope. So, some phrasings to use, like, talk to me, I'll listen. I really want to understand what you're going through. Another one could be like, I really understand and I hear that you feel like dying is the only way to escape your pain. And I know that there are other ways to relieve your pain besides suicide. I think that validates their feeling, but it doesn't, encourage them to actually act on their suicidal thoughts, expressing hope and belief that there's an alternative for them to help them feel better. You do want to be mindful of who is in the room with the patient. It's really ideal to interview the patient alone if possible, and then bring a family member back in, because that way, sometimes patients won't feel comfortable talking about this in front of family. And alternatively, sometimes family actually has useful information that they can share with you. So usually I have the family member step out and then they can come back in after a period of time. So that's where seeking collateral information from people who know the patient can be very useful. Whenever you're asking about suicidality, it's also important to ask about thoughts of harming the infant, since suicide and infanticide can sometimes go together. So language really matters, as I've been highlighting. So these are just some ways of maybe not asking these questions. Yeah, you haven't been having any suicidal thoughts, right? Um, and then I think sometimes people say things that are very well intentioned, but might be like just not well received. Like, oh, you don't really mean that. You don't want to die. You have so much to live for. It's not that bad. That's really invalidating. And I think it can just shut down conversations for patients. Or, yeah, what about your baby? Like, how could you hurt your family? Again, I think sometimes these are well intentioned, but you want to really create a safe, supportive space so that conversation can really open up from these questions versus shutting it down. So in terms of risk level and intervention, again, this is oftentimes these types of risk assessments are done by mental health professionals, but just to give you kind of a basic sense of how we think of it, a person who's at high risk of acting on suicidal thoughts would be someone who has a lot of risk factors, not a lot of protective factors, and has kind of through that spectrum of suicidality that I mentioned, they have ideation, a plan, access, and intent. Those are the people that we get really nervous about and recommend inpatient admission. So those are people who are at high risk. It's pretty clear. People who are at moderate risk are somewhere in the middle here. Maybe less risk factors, few more protective factors. They typically have suicidal ideation with a plan in mind, but they don't want to act on it. They haven't been engaging in preparatory rehearsal behaviors. So for these patients, you might think about a voluntary admission. You might think about intensive outpatient. You want to connect them with crisis services, but how it goes might depend on the actual patient. And then the patients who are at low risk would be those with not a lot of risk factors, a lot of protective factors, and then just having thoughts of death or suicidal ideation, but no plan, no intent. They can be managed most of the time in an outpatient setting, really focusing on symptom reduction. So that's just a brief overview of how you might kind of categorize patients very quickly. So in terms of what we do once we've categorized someone, we really want to address those modifiable risk factors. So if there is a mental health disorder or a substance use disorder, we want to treat that. So can you have psychiatry come to see the patient? Can you have addiction medicine come to talk to them about their substance use disorder? You want to make sure that they are engaged in care, and once they leave your setting, that they are referred to the appropriate level of care, whether it is inpatient versus outpatient. Psychotherapy, medications could be started potentially in your setting to help bring down whatever acute symptoms they're dealing with. Another strategy is just to increase connectedness, social connection. Having a network of support is very protective. So you want to make sure they have close outpatient follow-up, bolstering their professional supports, coordination with family and friends. There's also support groups to decrease that sense of isolation that can happen with patients in the perinatal period. And then there's also safety planning. This is really focused on restricting access to lethal means and is not a safety contract. I'll try to get through the next few slides on the faster side. So this is just an example of a safety plan. It looks at, patient will go through, what are warning signs of my, that I might act on suicidal thoughts? How can I cope when I'm having suicidal thoughts? Who are people that I can reach out to that could help me? And then how can I make my environment safe? So this is just an example of what that would look like. I'm not going to go over documentation, but just recognize that, what you document might depend on your given role. So these are helpful resources just to be aware of. Postpartum Support International is a wonderful, wonderful resource that I know that you all are probably very well aware of, but I'll just highlight that. The National Maternal Mental Health Hotline. There's lots of places that you can access suicide screening tools. There's, scales and things that you could use in addition to the safety framework that I just mentioned. And then Parents Thrive is another just repository of resource. It's a website, Colorado Crisis Service. And then I'll just highlight the clinic that I work at. We're always happy to see patients who need to be connected with care at the Women's Behavioral Health and Wellness Outpatient Clinic here at the University of Colorado. And with that, I will hand it off. I think, Christina, are you next?
Dr. Levin, that was awesome. Thank you so much. We will leave the chat open if anyone has any comments or chats that they want to send in for Dr. Levin while we move on. Hopefully we'll have a few minutes for Q&A at the end. But we want to keep moving because we had an excellent opportunity to talk to a local Colorado organization that is really tackling suicide. And so I was wanting to share with you guys the opportunity to hear about how they're doing it and what programming they're using. And so this is Christina Dolan. Christina is the Quality Outcome Project Coordinator for Centura Health. She coordinates, guides, and aligns programs related to suicide prevention and maternal mental health. She works closely with teams to develop and implement evidence-based best practice for suicide prevention and intervention. She oversees the collection of data to monitor the program outcomes and identify areas for improvement. She also collaborates with stakeholders to develop strategies to enhance the program. She is committed to improving mental health outcomes and reducing suicide rates. So Christina, welcome.
Thank you so much, Amber. And thank you so much, Dr. Lieben, for your very thorough explanation of suicide care. Let me see if I can get this going. Technology, it's just one of those things. It doesn't want to go into presenter mode, just like you were having. Okay, there we go. Okay. All right. So a lot of this stuff I'm going to really probably not spend too much time on because I know we don't have a ton of time today. And so unfortunately, I think you guys are already all very aware of suicide deaths in Colorado and kind of, where we rank. And then Dr. Lieben did a really good job of explaining what's going on with maternal mental health and those statistics. And then again, I think most of you are probably aware of this, but I just wanted to mention it. Among our kids, between 10 and 19, suicide is the leading cause of death among youth. And I'm sure you're all aware that Children's Hospital said that it's an epidemic with the increase. So anyway, all of these have kind of created the perfect storm to do some sort of suicide care at a systems level. So as Amber mentioned, I work for Centura Health, which has dissolved into Advent Health and Common Spirit Health. I am actually still on both sides just because both of them have such a commitment to suicide care that we just felt that it was really important to continue the great work that we had started with Zero Suicide. And some of the things that I just want to highlight with the Zero Suicide program is that the majority of people that die by suicide have actually visited a healthcare provider for medical concerns shortly before the time of their death. So you can see that 1 week, 33% have had a medical or mental health encounter. 1 month, that number rate is raised up to 50%. And a year before their death, 90% have had a medical or mental health encounter. The thing that I think is surprising is less than half of those encounters, the patients had any sort of a mental health diagnosis. So they might be coming in for a broken arm. They may be coming in to see their, their doctor for an annual visit. But most of those do not have any sort of a mental health diagnosis, which means that we really have an opportunity to ask the questions and really try to develop safer suicide care. So that kind of leads us into the Zero Suicide framework. And basically there are 7 things that Zero Suicide has identified as important to have a comprehensive suicide plan. I'm not going to talk about all of these today, but I will just quickly go through some of them. It kind of starts with lead. You need to have support from an executive level on down. It's great to have a lot of worker bees involved, but unless you actually have the buy-in from executive leadership, it's really difficult to make any sort of lasting change. Train, again, Dr. Lieben kind of referred to this. Your staff has to feel comfortable talking about suicide. And so it's really important to provide gatekeeper trainings to make sure that they feel comfortable asking the questions and that they also know where they need to refer folks to if they need to have some sort of higher level of assessment done. Identify universal screening is extremely important in knowing how or who is having suicidal ideation. Centura and now Advent Health and Common Spirit, they both universally screen everyone using the Columbia, which is a validated screening tool. And there's different versions of it. We use the 30-day version versus the lifetime version. And I'll go into that in a little while. Engage. Great, you've identified the people. Now, how do you get them treatment? So Engage is kind of a pathway that we've developed where there's different pathways depending on risk level, and we'll talk about that in a minute. Treat is getting them set up with the appropriate kind of treatment once you've identified their risk level, and then transition. What happens after they've had all of the treatment? What kind of follow-up care are they getting? And then finally, improve. How do you use data to determine where there are gaps and where you do have things that are actually working? Okay, I'm talking fast, guys, so I'm sorry. I know I'm kind of going through this. So just a couple of things that I really wanted to highlight. So as I said, we do universal screening. So the powers that be decided at some point that they no longer wanted to do universal screening because they thought it was a waste of resources, because when patients come into the emergency room, there are suicide precautions that are given to those individuals depending on where they score. And so they thought, well, why are we screening all these people? We can save money if we don't have to have sitters and, we don't have to have patients, go and just get into scrubs and all the different precautions that we have. So they made the decision for about 3 months to just screen people that had a primary behavioral health complaint. So what I did is I took all of the data from the previous year when we were universal screening, and I showed them that of all the patients that ended up scoring high on the Columbia, only 26% of those came in with a primary behavioral health complaint, which meant that we were potentially losing 74% of our high-risk patients. And in addition, our numbers supported that. Normally we see approximately 300 patients a month that have scored high on the Columbia. And when we were not doing universal screening, that number jumped down to 50. So we knew that we were missing patients. So to their credit, the executive team got together, they made a decision, and they actually reversed it. So we were universal screening, then we weren't, then we were again. And I think that's going to be pretty much the standard of care moving forward because the data supports the need for it. Maternal mental health, we do also do the Edinburgh with all of our patients. So this is obviously done outpatient as well as inpatient. So when I kind of just started taking over maternal mental health, and when I did, I saw that we were doing these screens and I thought, well, that's great, but what are we doing with this information? And so we weren't doing anything with the information. So just recently, what we've started doing is we actually send our quality teams at all of the hospitals the information. So for example, this is a hospital that I just pulled for the month of September. And our goal is to have at least 80% of our patients screened. So overall, it looks like we're doing pretty good when you first kind of look at the all hospital. But then when you go down to the ED, you see only, less than 60% of our patients were actually getting screened with the Edinburgh. So then what we did is we sent the actual patient numbers to our quality team, and we had them investigate at each of those patients as to why they weren't getting the screening done. What we found with some of them is that the patients were actively miscarrying. So of course, we don't want to do the Edinburgh on somebody who's actively miscarrying, but there were other circumstances where it just wasn't done. And so that was definitely a gap in our processes, and we're working to rectify that. Let's see, suicide care pathway. So depending on where a patient scores, we have a different pathway that is set up to help them. So as you guys know, everybody's screened in the ED with the Columbia. And then if based on the Columbia, they are determined to be low or moderate risk, we do exactly what Dr. Lieben was talking about. We do the safety and then we provide them resources. During that process, if they answer the safety in a certain way that they need to be bumped up to a high risk category, then we give them a full eval. And I know that I just pulled the data for June, and in June, I know that there were 70 patients that we did low risk evaluations of. Of those 70, 13 of them ended up having high risk evaluations done, meaning they were imminently suicidal. And of those 13, 7 of them ended up going into inpatient placement at a psychiatric unit. So it really shows that somebody comes in for low risk, they really can be high risk. You just have to make sure that you're getting them connected with the right person so that they're getting the care that they need. So after the screening pathway, what happens to them? They go on, they get their treatment, and then what are the next steps? So what I did is I developed a program called Caring Contacts. And what I do is I have a peer specialist who has lived experience follow up with every patient that leaves our EDs with anxiety, depression, suicidal ideation, or suicide attempts. And she follows up to make sure that they actually have connected with their resources. We're all great at giving resources, and then we send the patients out the door. But what actually happens to those patients? Are they really connecting with the resources? So many times when they're in the incident, they think they're just so overwhelmed, or they think, oh, I've got this handled, I'm not going to need it. And then they're back at home and they're alone. So we are very deliberate in our 72-hour follow-up. We don't want to do it right after the event because we want to give the dust a little bit of time to settle. And we really want to make sure that they have had time to realize if they need the help or to connect to the resources. So if they haven't been able to connect with the resources, then our peer specialist will actually get them connected with the resources and do warm handoffs. And this is also just really also helpful for us to determine our workflows, to kind of see what the quality is of our associates. Is there a certain nurse who's being dismissive of suicidal ideation? It really helps us from just a quality standpoint as well. I don't have much time, so I'm not going to talk about some of the other things that we've done to help with suicidal ideation, but I do want to talk about this real quickly. Just from the quality perspective, another thing that we've done is we have access to the death by suicide data from the coroner. So what this does is we actually take the data and then we cross-reference it with our electronic health records, and we actually see patients that we've seen within 90 days of well, we actually go up to a year before they've died, but especially that 90-day time period. So then we actually we have a group of doctors and people that meet, and we discuss each case that's been within 90 days, and we see where there were breakdowns in the system and what we could have done better. And there has actually been changes in policy based on our coroner data. Okay, I think that's about all my time, so I'm gonna stop.
That was fast and furious and such good information. I'm super impressed with all that you all are doing. I almost feel like we could host just a whole session on your program to learn more. I mean, guys, reach out. If you are interested in more about Christina, we could always host another Lunch and Learn or a Q&A session. And so let us know what your interest level is, because I was particularly impressed with your screening pathways. That's just really interesting. I'm sure a lot of these resources are open for sharing too. So guys, reach out. Sydney, I will go ahead, and we're running low on time. I'll go ahead and have you launch the poll while we put up Carly's slide. You all are probably very familiar with our labor and delivery nurse stigma and bias training. We've been promoting it heavily over the past month. This is a pilot project that we're doing. And so we're piloting in October. We're hosting 3 different sessions. Our sessions are almost completely full, but we've had so much interest in this stigma and bias training that's specific to perinatal health that we have an interest form. And so I would love for you guys to share this widely. It does not have to just be labor and delivery nurses. So for our future interest form, we're opening it to anyone. So social workers, inpatient, outpatient, providers, anyone that you think would benefit from this type of training. Feel free to have them fill out the interest form, and this will help us know how many sessions should we host in the future, what types of healthcare providers should we tailor the training to, and so this would be very helpful for us. We will send out these slides so that you can have access to this QR code as well if you'd like to share it widely at your facilities. Next slide. I think that was pretty much it. Is this it? Yeah, next month. I want to do a call out for next month. All of the nerds, calling all nerds, please. We want to talk to you guys through publishing. Publishing is a really critical part of quality improvement. Sharing what you're doing and what your outcomes are helps not only your facility, but facilities around the world, right? Learn from what you're doing. And so we're going to talk through some of just the really basics about how to create a poster presentation, how to draft an abstract for a podium presentation, what does it look like to draft a manuscript for a journal submission, what is the process for peer review, if your team is interested in writing an op-ed for a local or a national publication. We'll talk you through what that would look like. And so we're super excited about that. Carly Swinson, who just finished her PhD, is helping us with that. Very familiar with the publishing world. So join us, please. And then I think that is it. Oh, Gretchen has something to say. Please wait.
Yeah, I just had one quick note. Some of you may have received an email from me, just letting you all know that you will be getting some exciting access to your data dashboards through our website. So be on the lookout for a WikiLinks email in your inbox that will help you set up your password. If you have any questions, though, by all means, let me know.
Thanks for reminding me, Gretchen. Guys, we're super excited to have the dashboards on our website so that you'll have access through the website. We're continually building that out to have more resources for you in one location, including upcoming calendars and events in that one spot. And so, yes, watch for Gretchen's email. All right. If anyone wants to stay on for another moment, has questions, we'll open the mics. Otherwise, we are so thankful that you guys were able to be with us today. Thanks. And if you didn't already, please check out the chat. Excellent conversations happened there.